Thank you, Bassem. Wonderful demonstration. Any questions?
Any questions? Yes.
Yes.
Yeah.
So just a quick question. You don't look for the nerve anymore. You know where it is, so you don't have to look.
Only for no, not at all. Except if I want to show it to the fellow residents for them to learn what it is. But no, I don't see it at all. I know what it is. I leave it alone.
Okay.
And how far you take it from the lateral border of the scapula? How far you take the tendon?
The dissection, you mean, or the dissection? The dissection, superficial, you can go as much as you want. You can take a scissor and cut, I promise. You're not going to cut anything. The nerve is underneath the muscle. But usually I go around 2 centimeters just to make sure I have enough excursion.
And how far laterally you taking it?
Whatever that allograft will give me. Yes. How much I put the shoulder this
No,
way.
I mean when you take the muscle itself, the tendon.
Yes.
How far you go lateral? As far as you can?
As far as, yes, exactly. Whatever it is. Usually, this is why I make the incision horizontal. Because eventually the repair is more lateral.
Okay. Yes?
If you couldn't use the Achilles allograft, what kind of graft would you use?
Well, Philippe is here. Philippe Valenti. Yeah, Philippe is here. Philippe is using hamstring. George Athwal is using hamstring. In Europe it is. I'm really trying to find a way to get Achilles to Europe. It's a beautiful tendon. It's great, it's thick, it's very, very nice. But a hamstring in his hand worked very well. George Athwal the same way, did the hamstring very well. So this is what they've done.
And they do it like this? They pull it through the lower
Everything,
trap?
everything is very similar. Do you do it the same way, right? You do it attach first and go back to the trapezius. The same technique. And then you pass it through the lower trapezius. Yeah, the same technique. Yeah. Yes.
Fatigue over a period of time?
Can you repeat again? I did not.
No. As this muscle is doing a different function now, so is there any chance of muscle fatigue over a period of time?
Muscle what?
Fatigue, muscle fatigue or
Fatigue
muscle,
of what?
this lower trapezius?
No, lower trapezius is very forgiving, by the way.
Okay.
And what it does before, it even more than what it does right now.
Yes.
And you asked a question. They asked a question about scapular dyskinesia or scapular affection. I'm not taking the muscle out. I'm just lateralizing the insertion. So now it has double function on the scapulothoracic and glenohumeral.
Yes.
And believe me, I respect the scapulothoracic motion so much for me to do anything to affect it. I promise you.
Another thing, what is the usual diameter of this graft?
Achilles tendon,
Yeah,
around
thickness.
2 centimeter. And the thickness at least a centimeter.
Okay. Another thing, to act this graft like a SCR, is it possible to add one more anchor to the glenoid side so that we should have better compression on the human hand?
I honestly did it, and at least early on, I
Okay.
fashioned the graft almost with the rectangle in front of
Yes.
it. It did not make difference for me.
Okay.
So this is why when they ask me,
Yes.
I cannot justify it when you do trapezius with
Yes,
a big
yes.
tendon graft.
Yes.
So we have two more
you.
questions.
Yes.
This way?
Wonderful technique and very good demonstration of this.
Sorry. So I have a question related to healing between the autograft and allograft, because what we have learned in ACLs, the reconstruction of multi-ligament repair, eventually allograft is a scaffold and they give up. So does it happen similar way in your extension of the graft which you use the allograft? The healing between the original tendon and the allograft tendon is an issue?
First of all, I showed you in the prior presentation that wherever it heals on the bone, you take a biopsy, you have living fibroblast. Very sincerely, for the one I have imaging on, I don't have at all failure at the tendon allograft autograft interface. I have a 3 rupture traumatic that I have to revise, but none of them at the interface. And for me, based on my experience, even the wrist, also Philippe can talk about it, usually whenever you weave allograft in an autograft, like within, the failure rate is not high at all.
Because it's going to differ. If it's going to cause a fibrosis, then it is a tenodesis effect. If it is going to be muscle or muscle tendon junction, it's going to be a dynamic effect.
It's because this is musculotendinous almost.
So
yes.
it's a
Yes.
wonderful thing if it is going to heal there.
Yes. Yes.
One more question?
Marco Maiotti, last question, and then we go back to the live surgery.
Very good video. The question is, when is the first case you did, and I mean, how long is your follow-up? And you have to continue to control these cases to tell us how this surgery will last.
Okay, so the first case I did almost 13 years ago, and it was for brachial plexus. So I don't have the long follow-up for the rotator cuff yet. I'm following up on this patient. But the patient for 13 years ago, I have a video on him. I'll be happy to show you. He's still doing very well, even he has brachial plexus, no ER. It was the very first one I did, and he's still doing extremely well. Everything is working. For the rotator cuff, I have done them for the past 7 years or more. I haven't, the only cases I've revised, either traumatic rupture from trauma or arthritis like the case I showed you. But I haven't seen failure, but I don't have imaging like the control MRI, I don't have it, but probably we should do it. Yes, no problem.
Bassem has been very creative. The Mayo Clinic Brachial Plexus Clinic sees disastrous patients. And so he's been very creative at figuring out new transfers and teaching us all how to do them. It's been
Trying. Thank you.
So let's go back to live surgery.